Good afternoon. On behalf of the board and the incredible staff of NAMI, it is a pleasure to welcome you to our 2020 Virtual Scientific Research Award event. I'm Dan Gillison, NAMI's CEO. We are delighted you could be with us to celebrate Dr. David C. Henderson, our 2020 honoree, and his extraordinary work nationally and internationally to improve the lives of people affected by mental illness. NAMI is deeply committed to research as a major part of our mission. Research plays a critical role in inspiring hope. This award recognizes the work of researchers who move our scientific understanding and treatment of mental illness forward. After you hear Dr. Henderson's presentation, you will learn more about his experiences and contributions and the incredible impact that he has made. His tireless dedication is evident in his wide-ranging commitment to making a difference. As the nation's largest grassroots mental health organization, NAMI is dedicated to building better lives for the millions of Americans affected by mental illness. We are honored to have Dr. Henderson join the illustrious past recipients of this award. I would like to now ask Dr. Ken Duckworth, NAMI's Chief Medical Officer, to join us and tell us more about our honoree. Dr. Duckworth?
Thank you, Dan, and welcome everyone. I want to thank our sponsors and the Cohn family, but more about them later, for joining us for our 16th annual Scientific Research Award. This year's winner is a remarkable psychiatrist researcher who has really spanned the globe, trying to understand the best way to care for people in resource poor, sometimes trauma, and other complexities in their lives. Dr. David Henderson is this year's award winner. I could say a lot about Dr. David Henderson, but let me start by saying that he is the psychiatrist in chief at the Boston Medical Center, professor of psychiatry and chair of that department. He is also the assistant dean for diversity and inclusion at the Boston University School of Medicine. In his spare time, he's an adjunct professor of epidemiology at the Harvard T.H. Chan School of Public Health. David's national and international experience is a perfect prelude to his discussion today, which is entitled Moving Towards Equity in Health, Society, and Justice for People Living with Mental Illness. Dr. David Henderson, it's a great honor to have you present to our audience today, and I want to thank you.
Thank you, Ken. It's really great to be here. It's such an honor. I have been engaged with NAMI on and off over the years and have tremendous respect for the organization. And in fact, in much of my global work, I'm often asked about NAMI and how they do things and how things are set up. And so many countries are trying to imitate what NAMI has accomplished. So again, it's quite an honor. Now today I'm going to talk a little bit about my research experience, but also more moving towards like where should we be going around mental health and in this country and how can we get to equity and in the care of patients with mental illness. I think it's a really critical thing. Now, you know, when in much of my work from the past, I have focused a lot on the kind of the medical comorbidities related to people with serious or severe mental illness. And I've done a lot of research studies, both in trying to understand what are those factors that put people at risk, but then also to develop interventions. And I'll talk just a little bit about that before we really get into the meat of the discussion. Now, as you know, that people with SMI or severe mental illness, the life expectancy is much lower than the general populations, and in many studies it's estimated at least 20 years less than the general population. And again, there are lots of factors for that, including and much of my work was on the, in schizophrenia, for instance, and the antipsychotic medication causing weight gain and diabetes, lipid problems and cardiovascular disease. But then there's also, common comorbidities due to a number of factors like diabetes, cardiovascular disease, and cancers. And then some of it is related to lifestyle choices, unhealthy diet, lack of physical activity, excessive smoking, substance use. There's also, of course, a risk for accidents and suicide. And then finally, like the physical illnesses are diagnosed late and treated insufficiently. And I'm going to talk about that really because it does have an impact on healthcare delivery. Now, it's important for me to acknowledge that in looking at all of these things, we may have left out some of the most important factors that lead to negative outcomes in our patients. And we'll talk about the impact of stigma and discrimination and racism, the impact of stress related to social determinants of health that aren't completely addressed. And so we'll spend a lot of time focusing on that. Now, as you see that there are a number of physical illnesses that are increased in patients with severe mental illness, from bacterial infections to viral infections, respiratory infections, urological infections, and cardiovascular disease, and nutrition and metabolic diseases. Like obesity is actually quite common in some patients. And then that, of course, is associated with increased risk of diabetes and hyperlipidemia. And as you can imagine, particularly as we're living in a COVID world right now, there are many ways to actually get to obesity, and certainly with having a sedentary lifestyle is one way, and we certainly have been experiencing that as we've been isolated at home and so on. But as you know, that many people have a difficult time exercising in general, and as you can imagine, like this is a conference where you see that everyone is taking the escalator. Now, what's striking about this picture, it's just a bunch of people taking the escalator. Well, these are actually cardiologists and endocrinologists, and so the notion that we're all supposed to be exercising, the leaders in telling us that information are all taking the escalator. So I always find this picture quite funny. And then of course this is even funnier, people going to exercise, but they have to take the escalator to get there when there are stairs available. So you have to understand that. And so at the end of the day, it really comes down to this abdominal adiposity, and that really is associated with the diabetes risk and the cardiovascular disease risk. And certainly with our work with some of the antipsychotics, we know that some of the drugs contribute significantly to the abdominal adiposity and leads to the kind of bad outcomes that we've talked about. And so as you can tell, that like there are a bunch of things that impact mortality, and many of them are modifiable, including the lipids, the diabetes, the hypertension, physical inactivity, and smoking. Some other factors that are really critical are the access and the utilization of medical care. And as you know, patients with mental illness, there's a huge disparities in medical care. And there's been numerous studies that have identified much of it is related to decision making. Now, I once did a study with a bunch of social scientists where we were looking at really studying the effects of the antipsychotic drugs on health, but we wanted to study primary care doctors. So we developed a skit, and we went to New York. We hired some actors, and we changed the variables. But the skit was basically a primary care doctor interviewing a patient, and we changed the conditions. The patient could have schizophrenia, could have depression, or could have, I think it was eczema. We changed the diagnosis to but the medical conditions like the high blood pressure, risk for diabetes, the smoking were the same. And then we looked at decision making based on the patient's psychiatric diagnosis or non-diagnosis. And we found some significant differences in decision making. And the one striking thing to me was that the primary care doctors, and we interviewed 1,500, and they randomly assigned one of the videos, but the primary care doctors volunteered, many of them volunteered that they would tell their staff that the patient coming in had schizophrenia, just so to warn the staff. And you can imagine how awful that would be, and how stigmatizing, but how negatively it would have impacted on patients' care. And so so we have to really fight through this type of stigma within healthcare, and to make sure that people get the adequate care. I'll talk a little bit more about that. But also, we see that in economic capabilities also play a huge factor in this as well. Now, we know that some of the other reasons, they're less likely to be screened or treated for dyslipidemia, hyperglycemia, and hypertension, less likely to receive cardiac interventions like angioplasty, less likely to receive drug therapies proven to reduce, to improve the postmyocardial infarctions, and more likely to have premature mortality after a heart attack. And so there's clearly some issues with how the health of our patients is cared for. And when we've been going through an exercise at our hospital, really examining our data, particularly the health plan data, and it's so clear that how the mental illness is tied to the negative medical outcomes in our hospital. And so it's really something that we have to address. Now, this is a model that we had developed a few years ago, really tying all of those risks that were leading to cardiovascular disease in patients with schizophrenia, including the obesity and things we just talked about, the lipid problems, diet, inactivity, inflammation, and so on. And I think now, particularly as I've been working globally and certainly working at Boston Medical Center, which is a safety net hospital, I've truly have come to understand that there are other factors that are contributing that we never considered really in our studies, but patients live these every day. And these really are, the social determinants of health, the impact of food insecurity, trauma exposure, unemployment, education, lack of education opportunities, and then poverty itself. And we do know that for individuals who require government assistance, there is assistance, but it's only enough for people to survive, but it's not enough for people to thrive. So in other words, the assistance keeps people in a state of chronic stress that in fact the medications can't treat. Sometimes even the therapy cannot treat. And so we really have to come up with new models that reduce all of those other burdens so that people actually can get to thriving. And it's kind of like this model of kind of like we call it the allostatic loading, where basically it's the amount of stress you have divided by the resiliency factors, and then you come up with a number, and that number tells you is predictive of whether you're going to develop illnesses, usually chronic illnesses, chronic stress-related illnesses. And so we have to take into account all of those factors that are stressors. And patients with mental illness will have more stressors than the general population. They'll have, certainly they'll have some of the stressors will be the same, but they'll have additional stressors. And oftentimes, as I said, when trying to get people to really good outcomes and to, so their lives are completely normal and they're back to work and school and all that stuff, it's fighting an uphill battle sometimes, because there's just too many stress factors that aren't addressed, and sometimes they're not even understood or even asked about. So we really need to get to understanding the patient's life comprehensively, and all of those factors that are positive and negative, and working with that to get to better outcomes. Now, I know that NAMI spends a lot of time discussing and thinking about the impact of stigma, but I think that we have made progress in this country, but we clearly need to continue to push this along, because the impact of the stereotypes and prejudice and discrimination, persist, and I would say they're oftentimes stressful to patients and have a negative impact on their lives. And so you can imagine, patients, less likely to be hired, less likely to have apartments rented to them, more likely to be rejected by friends and family, more likely to be falsely accused of a crime, more likely to be arrested and spend more time in jail than someone else similarly charged. And as you know, the prison system and the jail system is filled with patients with mental illness. And at our hospital, again, we work with the courts in Boston to have mental health courts and diversion courts, so that we can try to reduce the number of patients who are arrested and end up in jail, versus we try to divert them back into treatment before they hit the legal system. So it can be done, and I think that needs to be really a national effort to do this. And as we're talking about, hearing about police reform and the legal system reform, this is clearly one aspect that needs to be attended to, because it, again, the legal system has become the de facto treatment setting for many patients with mental illness, and it's rather unfortunate. Now, as I mentioned before, government assistance it's actually, it keeps patients in a state of poverty, which is a state of chronic stress, but it also hampers clinics and hospitals and programs, because the reimbursements for mental health care through government insurance is lowest of any medical specialty. And so here are some old numbers, but if you can look and see, we see so psychiatry, for say 1 unit of effort, psychiatry would bring in $32.87, and now in 2020 it's $35.47. Now, for that same unit of effort, we can go to, say, a family medicine doctor would make $62.12. Dermatology, $94.49. And so the point is that psychiatry is the lowest reimbursed specialty. Even fine neurology. Neurology would make $48.91. it's the same organ. We're both talking about the brain. Someone decided what is a neurological disorder and what is a mental health or a psychiatric disorder, but it's actually the same organ. But they will be reimbursed quite differently just based on the specialty. And it's even possible that if a family medicine doctor diagnoses depression, they'll get that, $62. But if a psychiatrist diagnosed the same disorder, they'll only get the $35. So what this means is that mental health care does not have the funding available to provide the care that is actually needed to not only have medication and therapy, but all of those other support areas to address those social determinants of health. And we simply don't have the funding in order to do that. And I often say to people that if we had, in the general population, if we had the funding and resources that the Veterans Administration has available, then we actually would be making, we could do so much for our patients if we actually had those resources. And so we're way behind in this. Now I'm going to shift a little bit, because we have to talk about what has been going on in this country and really globally. There's lots of countries now that are where we're seeing people being outspoken about the police brutality, and certainly we've been experiencing this in this country, and so I just want to acknowledge that, but also acknowledge the impact of racism. There's overt racism and covert racism, and the overt racism, it's very obvious, and it comes with huge health and mental health negative outcomes. But even the covert racism, which are maybe much more subtle, have an impact on people's health and well-being. And then you can imagine if you already have a mental illness and you're experiencing these other types of racism and discrimination on top of the stigma associated with the mental illness, it has a negative impact and makes your getting well a lot more difficult. And if you look at all of the potential effects of the impact of racism, we see that it can cause a lot of mental health issues and medical issues as well. Increased stress-related disorders such as hypertension and so on. And so we have to be thinking about this in the context of our patients, what's going on in the world, and how is it impacting them. And we, in the last few months, I've spent quite a bit of time talking with my patients about the events and really listening to get an understanding of how those events have impacted them, but also how their own personal experiences have impacted them, and really how it actually impacts their engagement with the health system. So it's a really, really important area. And then of course we know that how police have treated people with mental illness. That's more coming to light, and as you know, it's just awful. We will have to do much more about the physical restraint, not only just by police, but we have to tackle what happens in hospitals and so on. And there are better ways of reducing the need for physical restraints, and that's something that we really have to address on a national level, local and national level. Now, stigma takes an enormous personal, social, and still unmeasured economic toll. That funding differential for mental health, it's huge. We have seen over several years, there are parity laws everywhere. There's national parity laws, there's state parity laws, but the truth is there is no parity. So we really have to get to this area for the funding in order to deliver care. Now, what's fantastic, with all of the amazing research and both in pharmacological research and therapeutic research, therapy like cognitive behavioral therapy, family education, work, employment assistance, all of those fantastic programs. Where we actually have great data that shows that these work and extremely helpful. Most places cannot actually implement those treatments and make them available. And again, it all comes down to the financial aspect of this system. So we have a system, a mental health system that's developed to help people, but by nature of the structure, it actually prevents people from getting well. And so that is something that we really need to push further on. And so we need to, from the stigma standpoint, address the media. You continue to work with the media to show the positive side of people with mental illness versus the negative side. And I'm a psychiatrist, and I love working with my patients, but my patients are not the mental illness. They are people who have medical problems, but they have whole other lives and things that are unrelated, and they're interesting and fascinating and creative and bright and all of these things. But that's not what is portrayed oftentimes. And so we really have to work with that. We have to work with employees. We have to work with landlords. Many landlords would try to block someone with mental illness from renting their apartments. Clearly, the criminal justice officials and law enforcement, I think there are some trainings of law enforcement that there needs to be a lot more, and there needs to be ongoing and so on. Now we have a ride-along program here in Boston that we've had 3 clinicians that work in the program, and the city of Boston has decided to expand that so that we will have up to about 20 clinicians available to ride with police when there's calls that they think may be related to a mental health or behavioral issue. And so we think that we'll be able to, number one, reduce the arrest, number one, reduce the use of force, and to get people connected to care. And so we're excited to expand that program. Regulators and government policymakers, it's critical that we continue to work with them and find the champions to bring about change. Providers in healthcare and healthcare systems need to take a look at themselves, look at their own data, identify those areas that can be improved, particularly as it relates to patients with mental illness and how they engage the patients and what the outcomes are and so on, because we have to get to better systems and better care. So if you think about this in general, so health equity is the attainment of the highest level of health for all people, and that economic status is important, really important. And as I said, it's really difficult when a patient runs out of money by the 15th of the month, and they have 2 more weeks before that next payment come in. You can imagine, number one, how stressful it is, but you can also imagine what behaviors it leads to in order for them to survive. And so that economic aspect is something that is important. Like at our hospital, we have a food bank, so I can write a prescription and send the patient down, and they will give them food for the week along with recipes. And I can say, you know, it's a diabetic diet or a low-cal diet and that sort of stuff. So that's actually very, very helpful. And then it's the factors, you know, race and ethnicity, language, and behavioral health. But achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So absolutely critical. And as you can see, that the systemically addressing the racial inequalities will require action to address the drivers of health inequalities within our hospital, in our community. So you can't be passive about this. Health systems really have to be very aggressive. And again, I think the you know, the bias in clinical decision making, it's easy to show this. It's very easy to grab data and look at outcomes and see how patients are treated differently. Unequal access to patient experiences and engagement. And first, in certain situations, we encounter, you know, someone say, well, the patients don't come in. And my question always is, well, why? And usually they have an answer. And I said, well, what does the patient say? What does the community say? You know, why are these patients not being engaged? And so, you know, it's very possible that, you know, the clinic, the hospital created one system and expects everybody to line up in that system. But in fact, different people think about healthcare in very different ways, and they engage in the health system in very different ways. And until we start asking patients and their families and the communities, like, what would work best? How do we, you know, what do you need in order to, you know, to remain in care with us? And what would get you here and that sort of stuff? What resources are needed? And still, until we start asking those questions, we're just going to have this no-show rate that will attribute the patients, and it may actually be the system that's the issue. And so we really have to work with the patients, families, and the communities to figure out how to best partner to get to the best outcomes. And so I think back one. So I'll end here, and again, I thank you very, very much for your time. As always, we have a lot of work to do. I think there's been a tremendous amount of progress, but there's still a lot more to do. But I think we can do it. And so it takes all of us to be, you know, advocates and to for NAMI members. And you know, I've always said that my patients who had their family members continue to be involved in their lives do better. And you know, it reminded me of you know, many stories in my global work where the families were integrally part of the care for their patients, even when they were hospitalized. So again, I do appreciate everyone's effort. So thank you very much.
Dr. David Henderson, thank you so much for everything you do and for this talk. We're going to take about 10 or 15 minutes to take some questions, knowing that there's over 500 people on this call. I hope you'll forgive me if I don't get to your question. The first question is a very NAMI question. I'm just an average person. How can I help to make things better? My sister was helped tremendously by a clubhouse. How do you think about the, now maybe there are no average people, because if you're on this, if you're participating in the scientific event, you're already thinking creatively, but it's a very practical, very NAMI-ish question. What can I do?
Yeah. Well, Ken, maybe we'll let you answer this question, but I think that first is, yeah, as Ken pointed out, like you're on the call, so you're doing something. You're you're here, you're looking, you're asking questions and stuff, and so we appreciate your involvement. And you bring up the issue about the clubhouse, which is fantastic, but many of them have disappeared because of the financial aspect, and so we need more of these types of services available to people. And so become an advocate, no matter where you live, what community you're in. You have to advocate for these types of services and so on, to make them available. Talk to your legislature, write letters, participate in events. But every person is important, and every person contributes, and so any involvement whatsoever, it's critically important. And then also continue to support your sister, and the family as well. So, and Ken, you may want to add a couple of things, but knowing NAMI very well.
Well, being part of the fabric of NAMI moves the entire equation forward, both locally to support that clubhouse and globally to change attitudes and ultimately funding streams. But I liked your answer, David. A different question. We shift gears a fair bit. I'm going to ask, there's a question about the ride-along clinician. As you know, the police brutality problem is extremely front and center in our thinking. And there are alternative models. I know there's one in the West called Cahoots. I know there's a program in Denver. Tell us more about the program that you're describing here in Boston.
Yeah, this program has been in existence for probably 5 or 6 years. It was started by a grant from the Department of Mental Health. And we put 3 clinicians into 3 precincts, and it actually was it's quite powerful. Like we looked at data. I think there were, like, let's say 500. If there were 500 encounters that could have resulted in arrest for people with mental illness, I think there were only like 150 arrests. And so first thing it did was it reduced, the number of arrests when the person may have committed a crime, and oftentimes, and we've done this study, I did a study years ago. Oftentimes the crimes are really minor, like trespassing, things like that. Violation of a restraining order to the parent's home, or so on. So it's oftentimes it's minor, and so we were able to divert many of those individuals from being arrested to get them into get them evaluated for mental health care. Now, in another portion of that 150 that were arrested, half of them were not physically arrested. They actually were giving a citation and they had to report to court. So instead of handcuffing them and going through all of that, they received citations and they had to report to court. So we were able to reduce some of that activity that would lead individuals to end up in jail. Now, the program also, I think, has, there were some limitations to the program, which we're working to fix now, because the numbers, for instance, our clinician was assigned to a police officer for their shift, and it was often random as to which calls the police officer would take. They would be listening in, and if there was clearly something around behavioral or mental health or stuff, they would jump in and try to take those calls. But in the meantime, they were also taking calls that were not related to anyone with mental illness and stuff. And so in essence, the clinician just sat in the car and did nothing. And so we have, as we are expanding to 20 clinicians in the city, we will we're also replacing someone with the 911 dispatcher, so that so we can play a role in determining where our clinicians should go. And so we hope that this would actually have a even greater impact.
David, I should mention that NAMI fought to have a 988 number that people in mental health crises can call. And the police officers, shouldn't really be put in this position to be the backbone for a fragmented and underfunded mental health system. And so the accomplishment of 988 will create this alternative pathway, hopefully across the country. Another question.
If that happened, that would be amazing. That would be absolutely amazing.
It's happening. It's happening.
It would help.
And you can thank your local NAMI. So we got it through Congress, and the president signed it. My understanding, it'll be rolled out in the coming 2 years. So this is just a good example of how NAMI's engaged advocacy, continues to make a difference. But it builds on work like yours, right? What you're doing is creative, is important, and we're trying to, work the other aspect of this. A question came in. Very few of us have international mental health experience. Do you have a story or a vignette or an observation from your work on the global scene that might be relevant to the equity conversation here in America?
Yeah, I've got like 100 of them.
Yes.
I think that a couple of things, I've learned a lot from my global work, and I brought things back to implement here. Now, I started to mention the issues of how families are involved, for instance, in the care. So my first trip to Uganda, I was getting a tour of the psychiatric hospital, and we went into one room, and I saw 5 people sitting on the bed, and I thought, wow, isn't this just awful? They have to put 5 people in the same bed. This is just awful. And so we talked in, and we went in, and then I realized there was one patient, and everybody else was the patient. Everybody else was the patient's family, and the patient's family would bring food every day, and they would rotate in, but they would stay with the patient all day, and they were involved in the patient's care, which made perfect sense, right? The patient is going to, in a few days, is going to be back home with the family. Who better to help while the patient is in the hospital, to make sure that what occurred in the hospital occurred back home? I thought, how, that's just an amazing concept. And here in the United States, the first thing we do when a person is hospitalized, we tell the family, oh, we'll call you when we're ready for a family meeting or something. Or they're not ready to talk to you, or we can't let you visit yet, and so on. And we cut off the most important support during that hospitalization, and it just actually makes no sense to me. So we have to swing back really to involve the family. Now, because of time, I have hundreds of stories about how Western medicine and mental health doesn't work so well in other countries, because we may over pathologize things that are completely normal in those countries and that sort of stuff. But because of time, if anybody's interested, please contact me. I can tell you a few stories. So happy to do that.
David Henderson, Unplugged on Western psychiatry. So the involvement of the family, right? Extremely important. And NAMI is really all about that. I want to shift gears again, which just speaks to how many areas you cover. You mentioned trauma. And of course, there are interventions like DBT that have been well established, to help people who live with traumatically fueled dysregulation. Do you have any thoughts about coping skills in schools, coping skills for life, perhaps before the trauma? And have you thought about a public health approach preventing some trauma? And have you thought about that internationally? Are you thinking about that in other places?
Yeah, this is a great question. I would say yes. Of course, I think that people people have done a lot of psychological first aid training, resiliency training. But as my former mentor, a guy named Chet Pierce, who guy coined the phrase microaggressions, would say to me, it says the only way to prevent trauma is to prevent trauma. Like the only way to not have, to have a traumatic event is for people to stop doing bad things to other people. Because if you think about it, we've had maybe centuries of trying to prepare people to experience trauma, and the military is a prime example. There's a lot of work that goes in to a young soldier in the training and so on, geared towards almost in a sense, and I could be wrong, and forgive me, but almost like to, I guess, normalize trauma, or to the expectation that they'll be exposed to trauma, and preparing them for that. But as you know, trauma's bad, and no matter what you do to prepare, there are a portion of people that it'll have a negative impact on. It probably has a negative impact on everyone, but there's a portion that will turn into what we would say is a clinical issue. Others may not meet the criteria for PTSD, but they may show some avoidance behavior, or they may have sleeping trouble, or some aspects of it, or cognitive difficulties. So in other words, I'm having seen a lot of bad stuff in the U.S. as well as in other countries. The only conclusion I have is that trauma is bad, and the only way to prevent psychiatric consequences is for people to stop doing bad things to each other. So, yeah.
David, we have a number of people with lived experience on this participation, which I think is a fabulous thing. One person said, you mentioned a lot of bad medical outcomes. And the person mentions they've had a lot of treatment, intervention, ECT. They don't have a good diet. They're isolated. Is the risk of premature bad outcomes the population? I think he's asking the question, can I adjust my own risk? Or because I'm in this population of people who've been discriminated against, don't have good access, I have some of these risks, is this destiny for me?
Yeah, well, I think I pointed out that many of the risks, some of the risks are modifiable, meaning that we can do something, about this, right? So yes, one can adjust your own risk. The notion of food insecurity. If that's an issue, then hook up with services that can assist you. The education, health, dealing with healthcare, be an advocate for yourself, and then we have to teach patients to be an advocate for themselves as they're engaging in the healthcare system. Like, how do you make sure that you're getting the right care and the best care? Make sure that you're being heard, and so get comfortable talking to your primary care doctor about your health problems and so on. Yeah, so there are a lot of things that can be done to reduce the risk, and make sure you exercise, get your steps in, you go walking, all of those things, lifestyle changes, smoking, alcohol, a bunch of things can change your risk. So again, a whole bunch of those things are modifiable. We can do things about them, and including some are within your control, but some also the health systems, within the health systems control. The health systems have to treat you fairly and equitably, and listen to you, and make sure, like, if you come into the emergency room and you have a psychiatric diagnosis, they automatically consider, oh, this is a psych problem, when you may have a medical problem going on. So we have to be strong about and push the system towards equity.
One of the other pieces I just want to mention is we have 2 sessions come up on NAMI's Ask the Expert. On November 5th at 4 o'clock, Dr. Eden Evans, who's a colleague of Dr. Henderson's, will be reviewing the literature on quitting smoking, which is the single greatest cause of premature morbidity and mortality in our population. And on December 10th, Dr. Gail Daumet of Johns Hopkins University is an internist, professor, and she'll be reviewing strategies she has studied to modify these metabolic risk factors. So, it's superb that you pointed it out, but I also want to leave people with the idea we are continuously engaged in education. And at this point, I'm going to transition to the award presentation. Dr. Henderson, you fielded a wide range of questions, I think wider than anything I've seen in all our years. So we're going to present you with NAMI Scientific Research Award. The NAMI Scientific Research Award honors individuals who are asking the most important questions and devoting their careers to improving the lives of people who live with mental illness. In 2013, a remarkable family stepped up and created an endowment to support this research. The endowment is called the Peter Corbin Cohn Endowment to support the NAMI Research Award. This was done by NAMI members and friends of the NAMI family, Jutta and George Cohn. These are lovely and generous people who are devoting a good bit of resources to making sure that research can get better. This award is in memory of their late son, Peter, who had a slowly progressive illness that morphed from depression, had some paranoia, and every single day they work to make things better. And by honoring Dr. David Henderson this year, we've approached the more global equity issues that are very important at this time. So now I'd like to present the NAMI 2020 Scientific Research Award to you for your extraordinary achievement in mental health research and for improving the lives. This is a very high-tech intervention that we've done. I'm passing the award through my computer to Dr. David Henderson. This technology is not available on the regular, but we thought it was essential. Yeah, don't try that at home. So there it is. David, congratulations, and thank you for everything that you do in service of our mission.
Well, then, Ken, thank you very much, and to the Cohn family. This is such an honor. As I said at the beginning, my interaction with NAMI has always been positive and inspiring, and it makes me work harder every day. And to be recognized in this way, it's just I think this is by far the greatest award I've ever received, and I really appreciate it and appreciate the support. So thank you very much.
Well, we love you, David, and I look forward to having you join us on our Ask the Expert going forward. The Ask the Expert is a monthly conversation with America's leading thinkers in research, clinical work, and peers. Now I'm going to hand it over to Dan Gillison, NAMI's CEO, to close out this lovely event.
Congratulations, Dr. Henderson, from all of us. We are honored to add your name to our eminent list of former award recipients. We look forward to hearing more about your work and the inroads you continue to make in the world of research and policy. This has been a fascinating and informative hour, and we are pleased that so many of our supporters and advocates could share it with us. Being virtual is fast becoming a habit, one that we are happy to have been able to adopt. While we miss seeing you all in person, NAMI hopes that as things change, so will we. In the meantime, we will see you virtually. Our many thanks and appreciation for your continued support and involvement. And until we meet again, be safe.